Hello, and welcome to this webinar on why psychiatry needs psychiatrists. I'm Dr. Rebecca Bernard. I'm a family physician with a practice in Fort Myers, Florida, and I'm the past president of Physicians for Patient Protection, an advocacy group focused on ensuring physician-led care for all patients. I'd like to start by showing you this photograph of my mother, Kathy Lample Bernard. This is her on her graduation day from Beth Israel School of Nursing in 1970, just a few years before I was born. I show you this photo for two reasons. One is to demonstrate my respect, admiration, and love for bedside nurses. And two, I hope that this photo helps to explain why I'm so passionate about quality care for patients with psychiatric illness. When I was about 12 years old, my mother was diagnosed with bipolar disorder with psychotic features. We lived in a rural, underserved area with limited access to medical care, and I remember my mom had to travel to another county for psychiatric treatment. This was in the mid-1980s, just before the development of SSRIs and atypical antipsychotics, and her psychiatrist did the best they could for her with the treatments that they had available at the time. My mom died at the age of 49, in part related to health complications from her mental illness. And as sad as I am at her loss, even now, 20 years later, I still cling to the memories of the care and compassion that psychiatrists and other mental health professionals provided to her. The treatment of psychiatric conditions is so difficult, and these patients, like my mom, are uniquely vulnerable. And this is exactly why psychiatrists train for so many years to make the correct diagnosis and prescribe the best treatments for patients with mental illness. This slide should come as no surprise for the psychiatrists in the room. This is what it takes to become a board-certified psychiatrist. 4 years of undergraduate training, which can be in anything, however, always requires core science. 4 years of medical school and passing multiple examinations, and then 4 years of residency training, after which you take a 9-hour certifying exam. During those 4 years of residency, psychiatrists in training rotate through a variety of settings: inpatient units, emergency departments, outpatient centers, correctional facilities, nursing homes. They learn how to provide in-depth psychotherapy and different types of therapy. They learn everything there is to know about psychiatric medications, including the mechanism of action of drugs and all of the potential drug interactions. There's a reason that psychiatrists go to medical school and do residency. It's because they need to learn how to become diagnosticians. In order to correctly diagnose psychiatric disease, they also must be able to exclude non-psychiatric medical conditions and also be able to treat psychiatric problems with coexisting medical conditions. In order to even consider all these possibilities, you have to have had an exposure to a great variety of pathology. As the saying goes, the eye does not see what the mind does not know. And without having an awareness of alternate diagnoses, one cannot even begin to contemplate them as a possibility. Of course, for psychiatrists that want to go on to care for children and adolescents, you will go on to take an additional 2 years of fellowship preparation. It takes a really long time to become a psychiatrist, and it's not an easy job. And now the demand for psychiatrists is exceeding the supply. According to HRSA, between 2016 and 2030, the United States will not produce enough psychiatrists to offset attrition, and it's estimated that there will be the need for an additional 18,000 psychiatrists to meet the demand. Of course, psychiatry is not the only field where we have physician shortages. Experts have been warning about a physician shortage since the early 2000s. But did you know that the physician shortage was actually created initially by a report that warned that the U.S. was producing too many physicians? In 1980, the Graduate Medical Education National Advisory Committee, also called GMANAC, published a report that they sent to Congress outlining and predicting a surplus of physicians and warning that the U.S. would have 70,000 too many physicians within the next 10 years. This committee advised immediate action, including closing medical schools and not allowing the entry of foreign-trained physicians. And I think it's really interesting that back in 1980, this group suggested that public policy focus on using non-physician providers. Within just a few years, other experts were calling out the GMANAC paper, noting that there were serious flaws in their calculation methodology. And by 1990, the year that we were supposed to have 70,000 too many physicians, well, it turned out that we were already seeing a shortage. But by then, national policy had already taken effect to stop the production of physicians. In the 1990s, medical schools were frozen. There was a serious restriction on foreign medical graduates. And of course, we know in 1997, there was freezing and a cap on residency funding. Despite the warning by many voices that we were facing a serious physician shortage, the U.S. pivoted, increasing the training and the funding for non-physician practitioners, including nurse practitioners and physician assistants. In 2010, the Affordable Care Act significantly expanded funding for nurse practitioner training programs without increasing physician residencies. And even today, despite a clamor of voices noting a serious physician shortage, very little has been done to increase the supply of physicians. You can see this very clearly in this chart if you look at the number of practicing physicians per 1,000 population, comparing the U.S. to other similar nations. In 1993, the United States had 2.12 practicing physicians per 1,000. By 2013, we had increased just slightly to 2.56. And then the most recent data that we have, which is 2020, we were up to 2.63 physicians. And this puts us at the very bottom of developed countries, with only Japan, Korea, and Mexico ranking below us. Instead of growing our physician population, the U.S. has focused public policy on increasing non-physicians, and here's the result of that, especially following the 2010 Affordable Care Act. You see here physician growth has remained fairly stagnant. We've been sitting at about 1 million for quite some time now, but yet there's been a massive growth of non-physicians, NPs in particular. This chart is from my book, Patients at Risk, which was published in 2020, and I had to just draw out the changes that have happened in the last 4 years because they're really remarkable. Again, you see physicians really about the same, but nurse practitioners, and the most recent data from this year, there are now 385,000 NPs. When it comes to psychiatry, rather than producing more psychiatrists, the U.S. is poised to produce more NPs and PAs practicing psychiatry. You see here almost 10,000 psych NPs estimated to be produced by 2030, and PAs about 1,500. And compare that with the projected estimate of psychiatrists, which is at about 9,500 in that same interval of time. So not surprisingly, with these changing demographics, patients with mental illness are increasingly receiving care from non-psychiatrists. In 2011, psych NPs provided 11% of mental health prescriber visits for Medicare patients, and in 8 years, that number increased to 30%, or 1 in 3. This represents a 162% increase in psych NPs treating Medicare patients, with a concomitant 6% decrease in psychiatrists. Now, in some states, nurse practitioners work in teams with psychiatrists, but in more than half the states of the country now, and all the VA facilities, nurse practitioners can treat patients independently without physician oversight. 21 of those states allow nurse practitioners to practice independently on day one when they graduate. 14 states allow independent practice after a certain amount of time under supervision. Physician assistants are now following the lead of NPs, and they have actually gained independent practice already in a number of states. While the NP and PA professions were originally created in 1965 to act as physician extenders and work under physician supervision, the goals have clearly changed. These are the strategic goals on the AANP, American Association of Nurse Practitioners website, stating Goal A, that patients will choose NPs as their preferred healthcare provider. They have a multi-million-dollar media campaign towards patients to get them to choose NPs as their care provider. And you'll also note Goal D, that the AANP is seeking that nurse practitioners be paid the same as physicians. Since many patients will receive mental health care now from non-physicians, we need to better understand their background and training. I'm going to focus on psychiatric nurse practitioners in today's talk because there are simply many, many more of them than there are PAs in the field right now. So what is the difference between a psychiatrist and a psychiatric mental health nurse practitioner, also known by the initials PMHNP? Well, the answer depends on who you ask. So I decided to ask Google because a lot of people are going to do that. And I asked, what's the difference between the two? And the answers that I saw over and over again on page after page were answers just like this one. The answers are, the main difference is that a psychiatrist is a doctor and a PMHNP is an advanced practice nurse. Essentially, the two jobs are identical. Here's another answer from the first page of HITS. They can do the same things as psychiatrists in appointments, including prescribing medication, and an appointment with a psych NP will look identical to an appointment with a psychiatrist. Patients can receive the same therapeutic benefits. Some sites will point out that it could be better to see an NP than a psychiatrist. For example, on this page, the site seems to say that psychiatrists often focus on medications, using them first, whereas psych NPs, drawing on their nursing background, emphasize holistic care. And this page is even a little more pronounced in its advocacy for NPs, saying that NPs might be better because they're friendlier, and psychiatrists, well, they may be more clinical and detached. If I'm a patient and I'm searching for information and I read this, well, that probably sounds pretty good. And it feels to me like maybe it makes sense just to go ahead and see a nurse practitioner because they have the same skill set and they have a better personality according to everything that I'm reading. Or as this meme likes to say, very common, we see this a lot, that a nurse practitioner has the brain of a doctor, but the heart of a nurse. Well, wait a minute. What if instead of Googling or asking NP-run clinics, we ask academic nurse researchers? Well, we do get a slightly different perspective. This is from a recent textbook called Clinical Simulations for the Advanced Practice Nurse. Chapter 11 focuses on psych NPs. And what it says is, in our current clinical reality, the psych NP is expected to function like a physician, despite the significant difference in academic and supervised clinical practice exposure. Quantitatively speaking, the newly trained NP likely does not possess equivalent knowledge, skills, and abilities compared to a newly trained physician. Any attempt to argue otherwise avoids an inconvenient and quantitative truth. And that makes sense considering the differences in the training pathways. I showed you the picture of the psychiatrist training, and I'm putting this up again so that I can give you a contrast between a physician training and an NP training. You can see that both of these start with a prerequisite of a 4-year undergraduate degree. Typically, that's a bachelor's degree in nursing, although I'll share with you some caveats later that some programs allow a registered nurse or RN without a bachelor's degree to get a master's or nurse practitioner degree without a bachelor's degree. And also that there are programs that allow non-nurses with a bachelor's degree in other subjects to directly enter into nurse practitioner school. But after the typical 4-year degree, then students will enter into generally a 2-year master's degree program for nurse practitioner certification. There are doctorate programs, but I'm going to focus on the master's level because that is the minimum way of entering the pathway. After that 2-year program, then nurse practitioners have a 4-hour exam, and then they can be certified to treat patients across the lifespan, including everyone from children to seniors. And there are a lot of different ways to enter that pathway. In fact, in 2017, there were 327 different programs allowing students to be certified as a psychiatric mental health nurse practitioner. The most common way, as I mentioned, is a bachelor's in nursing. However, there are bridge programs where you can go from RN into a master's level directly. And then one of the more common routes that is happening now is that you can have a master's as a nurse practitioner, say as a family nurse practitioner or in a different subject, and then do what's called a postmaster's certificate program to become a psych NP. And there's also some very interesting programs called direct entry, which would take you into generally a family nurse practitioner degree, and then you can do that add-on 1 or 2-year certificate. And a lot of these programs are 100% online. This is an example of a bridge program that takes you from an RN to a master's program in less than 2 years. A lot of these programs have low acceptance rates, and a lot of these programs have low acceptance standards. As you can see in this screenshot, there are many schools that boast 100% acceptance rates, so anyone that applies is accepted. Here are some ads for those direct entry programs that I mentioned to you. These are programs that allow anyone with a bachelor's in any subject to become a nurse practitioner without ever working a day as a nurse. And here's a screenshot of a new program that really astonished me, this one in Mississippi, because this was the shortest program I've ever seen. They're usually 15 to 24 months, but in this program, within 1 year, the fast track program allows a college graduate non-nurse to become a nurse practitioner. I like to show this slide because sometimes people will tell me that this isn't real, nobody's really doing this. Well, this is a real person, a picture of him he posted sharing that he's a nurse practitioner who never worked a day as a nurse. He got a bachelor's degree in psychology in 2015. He did an accelerated bachelor in nursing and then an MSN degree. So within 2 years, he had his nurse practitioner certification as a family nurse practitioner. Then he did an add-on certificate to become a psych NP. And as you can see here, he's sharing that he is now working all on my own in my primary clinic. And just for you to see that this is not just anecdotal information, the number of psychiatric nurse practitioners that are receiving their degree through these postmaster certificates is growing. You can see here, this is in the blue, the number going up and up. And also you can see that the number of students that are attending completely online training to become a psychiatric nurse practitioner is also growing. And we really don't have great data on the impact of online training, but there are some studies that are showing concerns about how well students retain information when it's learned online. Now, most NPs do start with a bachelor's degree in nursing, so I just wanted to share with you the sample curriculum, and it shows exactly what you would expect. Nursing students are learning how to become nurses. And we really need more bedside nurses just as much as we need more physicians. For nurses that are going to then enter to work into psychiatry, here's an ad to explain to you what the duties of a nurse are: to administer and note reaction to psychotropic drugs and other medications, to arrange further medical attention when necessary, assist the client in understanding what's going on and accepting the need for treatment, and helping to maintain a safe and secure environment for staff and patients. And these are really incredibly important jobs, and I cannot underestimate the importance of our bedside nurses, especially in psychiatry. But it's important to point out that the work of nurses does not automatically confer the skills that are necessary to diagnose and treat patients. And while nurses will certainly gain familiarity with common treatment regimens as they're carrying out orders from psychiatrists, Having a bachelor's in nursing or even experience working as a bedside nurse does not teach pathophysiology or pharmacology that is necessary for nurses to then take care of patients independently. That's why nurses then, of course, go on to get further education. So let me tell you a little bit about what they learn in that educational pathway. First of all, I want you to know that, as I showed before, there are a lot of programs that have 100% acceptance rates. And this is something that's changed a lot because in the past, only the creme de la creme of nurses got into nurse practitioner schools. And that's changed now, especially with an increase in programs. This is a typical program, one from Regis University. It requires a bachelor's in nursing with a GPA of 2.75 or higher and at least a C in nursing courses. It also requests 2 years of nursing experience, but that's preferred and not required. Most students will then attend a master's degree program. It usually takes about 2 years, and here's an example of a typical curriculum. I'll just point out here that this is the core meat of the coursework, which is a course on pathophysiology and physical assessment, a course on pharmacology. Those are general courses. Then we get into the third semester some psychiatric care, psychotherapy, and psychopharmacology. And then a course, I guess, wrapping it up or tying it together, which is managing psychiatric disorders across the lifespan. So those were the core classes, and then you're rounded out by, I would call them maybe a little lighter coursework, which is Introduction to Healthcare Disparities, Nursing Theory, Health Promotion and Maintenance, Ethics, and Business Management. And then, of course, we have to have our practical experience. And you see here that psychiatric mental health nurse practitioners, they have a core minimum requirement of 500 clinical hours to take their certifying exam. This curriculum calls for slightly more than that, 224 hours in the fourth semester, and then another 280 hours in the final semester. Now, we're going to talk about those clinical hours in just a moment, but before we do, I'd like to show you the curriculum of the postmaster's program to become a psychiatric nurse practitioner, because there's a really big interest in nurse practitioners in other fields entering into a psych NP pathway. And why is that? Well, if you look at what people are saying online, it's because many nurse practitioners in family and other fields, they feel that it is a more lucrative profession to go into psych, and also that it may be a better lifestyle. So the other reason is that there are really a ton of flexible, affordable options for them to get a psych NP certificate. Here's just a few programs that offer 1-year accelerated psych NP add-on certificates. And of course, there are longer programs that are part-time and allow NPs to even work full-time while they go to school. Most of the NPs that are getting these add-on psych certificates are coming through family nurse practitioner training first. That's the most common type of nurse practitioner. And I just want to share with you some concerns about what we're seeing with family nurse practitioner training, since many of these students will go on to work in psychiatry. In 2021, nurse practitioner researchers published an article that found that family nurse practitioner students, currently 59% of them are attending mostly or completely online training, and 22% of them were in direct entry programs for non-nurses. Of really serious concern, they found that there were major deficits in experience for these students. Many of them did not know how to take a basic history or physical. They hadn't practiced it. And 4% of these students had never once ordered a test in training, and 5% had never once ordered a medication. So once they graduate, though, these family nurse practitioners can then enter into a postmaster's psych program, and in 1 or 2 years, then become a psychiatric nurse practitioner. This is just a screenshot of a typical curriculum for that 1 to 2 year program. And here you see, again, 1 class on general pathophysiology, 1 class on pharmacology, and then you've got a class on foundations of psychiatric practice, general assessment and diagnosis of psychiatric patients, 1 class on psychopharmacology. and then one class each on the care of adults and one on the care of children. Of course, that's not a lot of training, which is why we are seeing encouragement for nurse practitioners to get a doctorate degree. But unfortunately, these doctorate degrees really are not adding very much clinical benefit. As an example, this is a very typical program, one at St. Louis University. And you can see here that most of the coursework is non-clinical. This degree includes courses on healthcare policy, leadership, clinical informatics, and really not a lot of clinical education. And in fact, that is the case for most doctoral level programs for nursing or DNP programs. This article from a very important academic nurse researcher pointed out that only 15% of all doctorates in nursing are clinical, and that 85% of them are focusing on aspects that are non-clinical, like administration, leadership, etc. Now, I want to take some time to focus on what is happening during those clinical 500 hours. It can be more, but 500 hours is the minimum, and the average for family nurse practitioners is about 686, and there's really no data that I could find on the average for psych NPs. This is a screenshot from Fresno State Psych Master's Program. It shows that they require 520 hours, and of those, 120 hours caring for children to then be certified to take care of children after graduation. And I'll also point out that not all of these hours have to be done with a psychiatrist or a psych NP. Some of those hours can be done with a non-prescribing clinician like a psychologist. Also note here that those clinical hours can be in any number of settings, and they can all be in the same setting. So really, a person that receives all outpatient training may have no inpatient experience whatsoever. And even further, those hours could even exclusively be performed on telehealth. This program says there is no limit to the number of clinical hours that can be received through telehealth. Same thing here at the University of Massachusetts, Amherst. There is no maximum or minimum hours for preceptorship via telehealth. Here's a screenshot of frequently asked questions from Liberty University. It's a 1.5 year long program. It includes 504 clinical hours. Of those, 280 hours in pediatrics. Half of those hours can be completed with a non-prescribing clinician, including a psychologist or even a social worker. Now, this program, it's interesting. It says that the students can work full-time. Most of the students have been able to do that, it says, and just that they need to be creative. And imagine a medical student or a resident working full-time while in training. Since the PMHNP certification allows nurses to care for any patient across a lifespan, I think it's really interesting to just see how many hours and how much experience they're getting with these different populations. Here you see this particular program requires 100 hours each with children and with seniors. That works out to about 2.5 weeks if you look at a 40-hour work week, although they tend to do things more spread out. But just for the sake of having an objective way of looking at it, 2.5 weeks of study to then be certified and take care of mentally ill children, senior citizens with mental health problems, 1 week in addiction, and 1 week in psychotherapy. Now, even though 500 hours isn't a lot of experience, it's really tough for nurse practitioner students to find a clinician for those hours to work with. As physicians, we were ensured that we would have a preceptor that had been properly vetted by our medical school and by our residency, but that's not the case for nurse practitioners. Many, and in fact, all of the online programs that I could find require students to find their own preceptors. And in fact, you can see here a Facebook page that is NP students in need of preceptors, 20,000 members seeking preceptors. And it's become big business where students actually are paying up to $1,000 per rotation to find a preceptor. It's really sad. I'm sure many of you have received solicitations from students that are desperately seeking a preceptor for their hours. And that makes it complicated because A lot of nurse practitioner educators have realized that students need more hours. And in fact, the recent update to the standards for NP education has advocated for an increase from 500 to 750 hours. And you would think that NP advocates would be on board with that, but not all are. Here's a screenshot from the National League for Nursing that strongly opposes the increase in number of clinical hours, saying that NP schools cannot handle that increased requirement and that it will decrease access to care. But what's so interesting is when they tweeted that, there were just dozens and dozens of NPs and NP students that said that the National League of Nursing was totally wrong and that the nursing profession needed to step up and put a stop to the schools that were not providing proper preceptorship, that hours should be increased, especially since now we don't have experienced nurses coming in. We have students in some cases who have never, ever worked a day as a nurse. There are many nurses that are speaking out about this. I've interviewed several of them for my podcast. And I think one that's particularly interesting for this talk is Rain Toman, who is a psychiatric registered nurse. And she actually enrolled in psychiatric nurse practitioner school because she wanted to learn more. And she dropped out of her program because she was so appalled at the poor quality of education. She said students were not receiving any lectures, they were given open book tests, and they were not given proper clinical preceptorships. She actually shared with us some screenshots from her fellow students across the country with similar concerns that students were not receiving quality education. And she also shared with us some evidence that this is why some nurse practitioners that are practicing today do not feel prepared to take care of patients. Here are some screenshots from a Psych NP Facebook page where practicing clinicians are seeking advice and help in treating complicated psychiatric patients, vulnerable patients like children and senior citizens and pregnant women, and seeking help because in many cases they don't have a supervising physician to ask, and so they're crowdsourcing information. And Rain actually checked all of these comments and found that they were coming from real practicing psych NPs. And it's really raising a lot of concerns about the quality of care, which truthfully, we don't have a lot of data about. I'm sharing some anecdotal information because frankly, we don't have a lot of legitimate hard data. We do believe in science, so we want to know, what does the data say? Well, I can tell you when it comes to the general care of by nurse practitioners and by PAs, that there is pretty robust data going back to about 1974. Remember, the first NP and PA programs came out in 1965, and one of the first large studies on NP care was published in 1974. It's called the Burlington Trial, and it found that when nurse practitioners worked side by side with physicians, patients got great care. They did prescribe more medicines and had higher labs and things like that, but ultimately, patients got good quality care. And studies have shown that over and over again, when doctors and NPs and PAs work side by side together, we can do a great job in teams. However, if you look at the data going back for 50 years, you cannot find a single randomized controlled trial evaluating care provided by NPs or PAs that are practicing without physician involvement, especially if you're trying to find studies that are not on very low risk, minor issues, or when you're looking at the care of typical or undifferentiated patients. There just is no data there. When you look at psych NP data, then there's even less information. There's a 2004 literature review, and it found no specific outcome studies for nurse practitioners in mental health. A 2016 study of NPs in psych NPs in public health found that there was significant knowledge gaps. A 2020 review of NPs, psych NPs working with children found no outcome data. And a 2022 report on psych NP workforce and access to care found two studies, and they weren't that great. One was from 2018. It found that NPs were more likely to prescribe psychotropic medications to children on Medicaid than were non-NPs, than were psychiatrists or primary care doctors. And in 2022, a study found that NPs and PAs prescribed more benzos and more opioids to nursing home patients with dementia. So that's concerning. And then also, if you look at some recent data from the DEA on prescriptions of stimulant drugs, specifically for ADD, you see in the left-hand slide, there's a big increase just in total number of prescriptions. But when you look on the right, those increases are almost exclusively coming from an increased number of NPs prescribing. And that's not just a telehealth loosening, because this goes back to pre-COVID. I mentioned that we have a lot of data going back to about 1974 showing that working in teams, patients get good care. But those studies also show some concerns, which are that NPs and PAs order far more tests than physicians do in order to provide that care to patients. They prescribe more medications. They have lower quality referrals and may increase the number of referrals, therefore causing more issues with our physician shortage. And ultimately, several studies have shown that NPs actually end up being more expensive to the health system, and they don't necessarily lower staffing costs, even though they may receive less pay. But even though we have this data, what I often hear from legislators is that, well, that doesn't really matter, because the one thing that matters above all is patient access to care. And I think there's this idea that some care is better than no care. But the truth is that thinking is completely wrong, and I'll explain to you why. A large study published in The Lancet in 2018 by Harvard School of Public Health looked at worldwide deaths and found that more people die across the world due to poor quality healthcare than die due to lack of access to healthcare entirely. And although this may sound counterintuitive, what happens is when you have an inadequately trained clinician, they may make the wrong diagnosis, leading to delays in proper care, or they may prescribe medications and treatments that end up harming patients when those patients might have gotten better on their own. What we find here is that access only matters if it's access to high quality care. Anything less is more likely to cause harm than good. So we need to know more about what is happening, especially since we know that many patients, especially in independent practice states, are receiving care from NPs without physician involvement. And it's particularly an issue in rural areas where in those independent practice states, NPs are providing more than 50% of psychiatric care to those patients. I would argue that underserved and rural patients, like my mom, deserve the same care that any patient receives, those that live in big cities. But the reality is that we're seeing the development of a two-tier health system. Low-income patients and those from racial and ethnic minority groups, and as this talk shows, patients with mental illness and substance abuse are more likely to see an NP and less likely to receive access to a physician in states that allow independent practice. That's also the case for community health center patients, whose studies show have much higher mental health needs than similar patients of low-income areas. What's interesting is that now that we've opened the door to allow NPs to practice independently in the name of access, we're decreasing patient access to psychiatrists, and it's emboldened healthcare companies to actually fire psychiatrists and physicians in general and replace them to save money. In December of 2022, Sacred Heart Hospital announced the firing of 8 psychiatrists in order to save about $3 million per year. The chief medical officer told reporters that they would be replacing the psychiatrists with 3 NPs to serve psychiatric patients, which I imagine would be pretty simple in Washington state where they have independent practice. It wasn't an easy decision, Getz said, but it was the decision we need. And I suppose it was the decision they needed in order to continue to pay their top executives top dollar. You know, Sacred Heart claimed to be in such financial distress that they had to save $3 million by firing psychiatrists. But in the revenue cycle previous to this, they reported paying their outgoing president almost $11 million, and their incoming president, $4 million, as well as many other executives making 6 and 7 figures. They also paid for first class and charter travel and provided discretionary spending accounts for executives. And of course, this isn't just happening in psychiatry. For those of you looking for your own physician, you probably are having a hard time finding one because doctors are being replaced across the country. So now that we know a little bit more about what's going on, the question becomes, what can we and what should we do about it? For me, it really comes back to medical ethics, and you know this topic more than I do as psychiatrists. I think if we're giving our tacit approval to the replacement of psychiatrists by non-psychiatrists, or if we're just turning a blind eye to what's happening and saying, well, there's nothing I can do about it, I think we're running afoul of our ethical obligations to help patients, beneficence, and to do no harm, non-maleficence. I also think of the duty to warn, to let patients know that they may not be receiving the right health care. The Flexner Report in 1910 established the minimum standards for medical education, and they made it very clear that physicians need a strong science background and that an apprenticeship model was unacceptable. Ultimately, we're returning to a pre-Flexner model when we as physicians accept minimally educated clinicians, allow them to work under our license for a few years, and then set them free to work alone. By participating in this model, we are contradicting our oath as physicians to protect our patients. Another core tenet of ethics is patient autonomy, or as they call it here, respect for persons. And it means that patients should have the right to make their own choices, but that patients must have the proper information for informed consent. NP training is not the same as psychiatrist training, but patients don't know this. I showed you those screenshots where patients are being told there's no difference. And further, patients may not even be able to figure out who is taking care of them. This advertisement for a psych NP shows the words psychiatric care, it shows doctor, but how does a patient know that this is a nurse practitioner and not a psychiatrist? They don't necessarily know what this alphabet soup of initials really means. They may just see psychiatric and doctor. Another factor when it comes to autonomy and ethics is to provide special protections to vulnerable populations. And I would argue that many psychiatric patients fall into this category. I know that many of you have dedicated yourselves every single day to take care of patients with mental illness. You work so hard for your patients. And my ask to you today is to consider more than just your day-to-day practice, and you work so hard every day, but we have to go a step further, which is to consider our role as physician leaders to ensure that patients receive the best care possible, and to be sure that patients with mental illness have their care led by a psychiatrist. There are solutions, but they're not going to be easy, and they're going to require our buy-in and us working together. We need to fight to ensure that we reverse this manufactured physician shortage. We need to fight to make sure that we have enough physicians. We need to make sure that residencies are funded, and we need to help physicians want to stay in practice by paying them and treating them fairly. We need to work to put a stop to NP diploma mills and to help them to standardize their education. We really, really should return to the traditional and scientifically proven model of NPs and PAs practicing under physician-led care teams. And really, physicians, we have the responsibility to make sure that when we do supervise, that we do it properly. I really urge you, if you're going to train or work with a nurse practitioner or a PA, you need to know their background and their training and their education. Spend time with them and don't just sign off without really knowing what kind of care they're providing. I'm sharing this screenshot from a psych NP who is seeking a collaborating psychiatrist. And I would say I don't love the word collaborator. Doesn't sound very good, Really, it should be about supervision. This person is letting you know that they are an online trained exclusively NP who was a psych nurse for 5 years in an inpatient unit. They're offering to pay $200 a month because they say that you as a collaborating psychiatrist really shouldn't have much to do other than the required reviews to pacify the current Oklahoma regulations, is what it says. And this NP truly believes, as they put here, that by utilizing the, quote, recommended DSM-5 step-by-step algorithmic diagnostics and treatment strategies, that he will be able to provide complete care to psychiatric patients. To me, this is total hubris because it's someone that doesn't understand that patients don't always fit into algorithms. I think about patients like my mom seeing a brand new online trained NP grad without a true psychiatrist involved in their care, and it breaks my heart because psychiatry needs psychiatrists. You can learn more from the group Physicians for Patient Protection. Our website is physiciansforpatientprotection.org. Please check out my books. There's over 1,000 citations between the two books. And don't hesitate to reach out to me directly for questions, comments, or feedback. Thank you so much.